Good afternoon, and thank you for joining today's PCPCC webinar, Putting the Mouth Back in the Body. We will soon learn from experts about the challenges and opportunities regarding the integration of oral health and primary care. I'm Ann Greiner, President and CEO of the Patient Centered Primary Care Collaborative. And before we get started, I wanted to take a moment to give a brief preview of some exciting webinars that are coming up in the next couple of months. On April 15th, we'll be joined by Dr. Sachin Jain, Head of CareMore, Dr. Guru Dayal, President of New Markets from ChenMed, and Dr. Ann Huang, Director of the Center for Consumer Engagement and Health Innovations at Community Catalyst. These three experts will discuss primary care innovations in the Medicare Advantage space. In May, we're hosting a webinar on the emergence of AI and its potential in primary care. Registrations for both webinars will open soon, so please check our website in the coming days for more information. Also, please be sure to save the date for our annual conference that will be held this fall in Washington, D.C. on November 4th and 5th. Finally, I'm very pleased to welcome all of you, and we have over 250 on the call today, to our webinar, and to let you know that you can engage with the PCPCC, its members, and its board even more directly by becoming an executive member if you are not already. If you're interested, please contact Jennifer Renton at jrenton@pcpcc.org. Now let me introduce our panelists. I'm really pleased to welcome all of them. Let me first start with Aneta Duell-Glicken. She's currently Associate Dean and Professor Emerita at the University of Colorado School of Medicine, a wonderful place, and she has over 30 years of administrative research and educational experience. Aneta was a founding member of the National Interprofessional Initiative on Oral Health and is now serving as the organization's executive director. This organization provides backbone support and really is the national voice for interprofessional integration of oral health into primary care. Thanks so much, Aneta, for all your leadership in this area. Aneta is joined by Kelly Orenberger, and Kelly is the Manager of Interprofessional Practice at the DentaQuest Partnership for Oral Health Advancement. She oversees projects and programs related to medical and dental integration and coordination, including the Medical Oral Expanded Care, or More Care program, whose interprofessional framework has been tested and implemented in several states throughout the country. And those of us who have been in health policy for a while know that states are often the laboratories for innovation that takes hold across the country. And lastly, but not least, is Kimberly Robbins, and she has been the Pediatric Primary Care Practice Administrator with Child and Adolescent Clinic for the past 32 years. At this clinic, she's been committed to open access for all children, regardless of insurance coverage. The clinic that Kimberly works for cares for more than 15,000 clinics. It's located in Southwest Washington, and it's had an oral health program for more than 10 years. Kimberly is passionate about the benefits of oral health in pediatric primary care after seeing firsthand how beneficial these programs can be. As we're going through the webinar, please feel free to submit your questions into the chat box so we can address them during the Q&A after the presenters finish their remarks. Now let me turn the floor over to our first panelist, Aneta.
Thank you, Ann. In February 2007, when newspapers across the country carried the story of the death of 12-year-old Diamante Driver, if you were a physician, a PA, a nurse practitioner, you might have read the story, shook your head, and said, how unfortunate this family couldn't find a dentist. Too bad we couldn't do anything about this. Well, 10 years later, those same clinicians, primary care providers, are learning that by redefining the problem and viewing it through the lens of an integrated healthcare delivery system, they're an important part of the oral health solution. So how did we get here? In the U.S., patient care, as you know, is typically fragmented. Many of our see a physician regularly who may not visit a dentist. And this data doesn't include PAs, nurses, and others who provide primary care. This slide documents 108 million missed opportunities for primary healthcare providers to engage patients in education, preventive oral health care, and screening for identification of disease and referral to dental professionals. But fragmentation doesn't just impact providers' communications to a patient, it also impacts the flow of information. As depicted on this slide, typically there's little to no communication between the dental and medical care practitioner silos. And in this example, the flow of information about the diagnosis and treatment of a chronic disease like diabetes is heavily reliant on the patient acting as conduit, which is not only a serious burden on the patient, but also is often an unreliable means of communicating critical health information. We also know that in addition to fragmentation of care, basic access remains a significant barrier, with 62 million Americans living in dental health profession shortage areas. And where do they go? They often end up in the rabbit hole of our nation's emergency rooms, where providers are often unprepared to deal with their concerns. This issue of insufficient dental health professionals to care for the population will not be resolved soon. So as a country, we needed to consider who else could be recruited to participate in prevention. So in 2009, to address this issue, the systemic problem, NIOH evolved as a consortium of funders, health professionals, and national organizations with a shared goal of eradicating dental disease. Our assumption was that if we could integrate oral health into education and professional coursework, providers would enter the workforce ready and willing to partner with other health professionals to create a new standard for oral health in primary care. The NIOH is a systems champion. As Ann said, we provide backbone support and facilitate interprofessional agreement and alignment across health professions, interprofessional workforce for oral health care. Oral health integration isn't a new concept, and this graphic illustrates, let me go back here if I can, one slide. This graphic illustrates the opportunity for change. We see the progression of the field and the growth of policy documents that over the last 20 years have been driving change across our healthcare system. And two of these documents have given a big lift to the oral health movement. HRSA's report on the integration of oral health in primary care practice describes what we can do by defining a set of oral health core clinical competencies for non-dental providers. The Interprofessional Educations Collaborative, Core Competencies for Practice, describes how we'll work together in a collaborative, team-based environment. However, we recognize that these and other scientific evidence is important, but change happens not only as a result of the research and policy analysis that advances our thinking, but also as the result of the investments we make in recruiting people that can make change happen. Therefore, since 2009, NIOH strategically seeks to promote change through activities that cultivate leadership, facilitate interprofessional learning and agreement, and provide tools and resources that create a common knowledge base and vocabulary to bridge understanding, communication, and skills related to oral health. These strategies inspire a philosophy of collective impact, where we work across health professions in mutually supportive ways that help us create a movement that drives change. So let's shift our attention to two of the many tools and resources that are helping prepare this primary care workforce to integrate oral health. Smiles for Life, a free product of the Society of Teachers of Family Medicine, is the nation's most comprehensive and widely used oral health curriculum, specifically designed by and for primary care clinicians. We have 8 independent modules that extend across the lifespan to cover the unique oral health issues at each stage of development. The modules can be used as educational coursework as it logs and tracks progress through a back-end database. And SFL, Smiles for Life, also provides many health professions with up to 8 hours of free continuing education. The modules are interactive and engaging, with self-assessment questions, games, and case-based learning. And because it's profession neutral, The modules can also be used by practices and health centers to educate all staff on a common oral health curriculum, including specific instruction on team-based interprofessional care. In addition to the course modules, Smiles for Life has multiple resources, including pocket cards, educational handouts, state-specific resources, and a fluoride varnish implementation manual. The endorsement of 8 health professions and 20 professional organizations documents the widespread acceptance of the curriculum, as well as growing interprofessional agreement on the need for shared ownership of oral health care. This year will take us over the 2 million mark in discrete site visits. By the end of 2018, we had almost 300,000 courses completed for credit by registered users. It should be noted, however, that anyone can use Smiles for Life without registering, because faculty can also choose to download modules or slides and lecture notes. So our numbers only recognize a percentage of those actually using the curriculum. While the Smiles for Life database tracks the spread of the curriculum, it doesn't help us understand how the curriculum might be impacting practice or patient outcomes. In a recent survey, we asked users whether the curriculum has influenced activities by leading them to start the activity, perform it more regularly, or perform it better. Providers reported that it influenced many oral health activities, particularly those that required more specialized oral health knowledge. Let's drill down a little on this. Referrals are something we would routinely expect providers to do, yet even with that, we see a third appeared to do this more regularly, and 40% felt they did this better. In terms of anticipatory guidance, 60% said they did this better, and almost 50% said they began applying fluoride varnish as a result of the curriculum. Almost 60% said they do a better job at caries risk assessment, with about the same number conducting a better oral exam, with 50% feeling they do a better job of oral cancer screening. In summary, we found that Smiles for Life appears to positively influence the practice of oral health across professions. We also learned, however, that organizational factors may influence the uptake of oral health activities in primary care, because we're often faced with significant challenges when it comes time to integrate oral health in practice. Which leads me to the second tool I want to mention. In 2014, but with funding from Arcora, the DentaQuest Foundation, and the Kansas Reach Foundation, we could commission Qualis Health to create a framework and toolkit that would make it easier to integrate oral health in primary care. This white paper makes the case for oral health integration and goes on to define an oral health delivery framework for practice integration, addressing 5 actions teams can take to protect and promote their patients' oral health. Ask about risk factors and symptoms, look for signs of oral health or active disease, decide most appropriate responses, act to offer preventive interventions or referral for treatment, and document through structured data to support shared decision-making and population management. In order to test the framework, the NIOH helped support work to evaluate how various integration models address the oral health prevention gap, those missed opportunities that I referred to earlier. 19 diverse primary care practices participated in this effort, including urban and rural settings. The sites each selected a specific patient population, and we had 5 different electronic health records. In 2016, Qualis Health released an implementation guide, a toolkit reflecting our experience field testing the instrument. This guide is free and includes specific tools and resources practices found helpful. For example, referral agreements, patient engagement strategies, and case examples. These tools allow settings to customize integration efforts based on the setting, staffing, and patient population. There's clear synergy between our work and that of the PCPCC. We were pleased last year to see oral health specifically called out in the principles of person-centered and team-based care. The patient-centered medical home and advanced primary care are key settings for the integration of oral health. We need to continue to work together to create a shared vision for whole person care across our medical and dental silos, and work to define shared performance measures that will catalyze new evaluation strategies with a focus on prevention, value, and population health. So what have we learned? We've learned that the organizational change process requires system-wide intervention, that having the right people in the right place for the right reason can change ideas and practice. A key is having the right tools and strategies to impact knowledge and skills and attitudes of providers. And collaboration is key. We can't have an integrated care system that treats the whole person by continuing to work in silos. And we can't do this work alone. We want to specifically thank our legacy funders, the DentaQuest and our Cora Foundations, and core partner Judy Haber, who directs ONEP, the nursing arm of our initiative. Working together, we can move beyond the symptoms of health disparities as we aim our work at changing the structure that creates those disparities initially. Thank you. I want to turn this over to Kelly.
Sure, thank you, Aneta. I'm going to just take a few minutes to build off of the groundwork that was laid earlier about why integration is important and just talk a little bit about the model that the DentaQuest Partnership for Oral Health Advancement has built and modified over the past couple of years. So in addition to the statistics that Aneta just laid out for us a few minutes ago about the disparity between the number of people who see a medical provider versus a dental provider, we also know that the mouth and the body are connected. We know that there's correlations between oral health and overall health, and understanding the need for the mouth to be placed back into the body, and also that the siloed nature of the medical and dental systems currently has really led us to creating the More Care framework. So More Care, which stands for Medical Oral Expanded Care, was developed in 2015, and between that time and today, it's been piloted in 4 states, South Carolina, Pennsylvania, and Colorado, and we're just beginning to work in Oregon. The initial focus of More Care was on rural areas, specifically working with primary care rural health clinics. And in each of the states that we've worked in, we partnered with either state offices of rural health, universities, or other state-based partners to ensure that the application of the model was relevant and customized to fit the local environment of care. Just a note also that in addition to our internal project team, we've also worked with expert faculty that are from primary care, pediatricians, family practice doctors, nurse practitioners, nurses, and they have all helped to sort of develop and implement this framework. So the aim of More Care is really to create a new way to improve health by addressing oral health through interprofessional practice. There's 2 main ways to achieve interprofessional practice that we focus on during More Care, which is integration and coordination. When we really talk about integration, we're focusing on the primary care office integration of oral health activities, meaning how oral health activities can be integrated into the workflow and care of patients in the primary care office. And the second way we'll work to achieve our goal is through the coordination of care, which includes working with dental providers. Coordination speaking to figuring out sort of how primary care and dental providers can refer and communicate with one another to ensure that patients who need care receive it in a coordinated way. And so here we have what we call our pathway. The one that's on the screen right now is for pediatrics, but we also have one for adults that I'll share next. And what this really depicts is the activities and specifics around what happens in the medical and dental care teams. The left and right-hand sides of the pathway speak to integration, which we mentioned on our last slide. And the middle box really speaks to coordination of care. So the left-hand side, the medical side, shows the integration activities that occur in the primary care office, which center around evaluating oral health risk, setting an oral health self-management goal, applying fluoride when necessary, and referring patients to a dental provider. And I'm not going to go into too much detail about the adult pathway since there are quite a few similarities between this and the previous slide, but the activities really are modified to fit the unique needs of adults. This focus of the pediatric activities are looking at caries or cavities, whereas on the adult side, there's a greater focus on periodontal or gum disease, medication management, and also looking at the correlations between oral health and other chronic diseases like diabetes and cardiovascular disease. So in terms of how we applied the More Care framework, we used a modified version of the Institute for Healthcare Improvement's Breakthrough Series collaborative model. And each state we had participating medical clinics use the Smiles for Life modules. And in places where there was an in-state oral health training program that existed, the clinics also participated in that to really develop a solid understanding of why oral health was important and what were the activities that would be done in primary care. What we did throughout the course of the collaborative was really work with the clinics to come up with the how. How would they integrate these activities into their practice in a way that was efficient, effective, and sustainable? We use the model for improvement to help guide the clinics through testing various change processes. We work with the clinics to do PDSAs for how to integrate things like the oral health evaluation into their workflow. Once processes were tested and stable, we could then sort of switch to thinking about sustainability and spread, answering questions like how do we make sure that oral health integration continues when someone leaves or our new staff or providers onboarded, and how do we learn with one population and modify it so that we can begin to address oral health in a different patient population. And as I mentioned earlier, this work was really accomplished in a model in which the participating clinics were able to share ideas with one another and support each other with feedback and with the support of our expert faculty from both primary care and dentistry. Some of the tools that the clinics use along the way that you can see here are flip charts to assist the primary care providers in engaging in an oral health discussion with patients. We also had many clinics test out the use of other visual aids, posters, books in the waiting room, other oral health related prompts to really determine what sparked an interest and conversation about oral health with patients. And many really did find quite a bit of success in using some of these materials as conversation starters. We also developed a document of ideas that for clinics to try for each part of the More Care model, and these really sort of help the clinics get started on testing ideas and seeing what's worked in other clinics that they might be able to adopt or adapt for their own unique environments. Throughout the collaborative, we looked at several process measures related to integration of oral health into the medical practice that you see here. On the right-hand side, you'll see that there's also a measure that speaks to the coordination of care between medical and dental. One thing that I should note, and really this is more of a lesson learned, but we found that the coordination of care between dentistry and primary care was quite a bit more difficult to achieve than the integration of oral health in the primary care office for a lot of different reasons. But on the right, our primary care measure for referrals is actually broken up into smaller pieces with some responsibility on the primary care side and some on the dental side, because this is an activity that really requires both sides to participate to achieve that end goal of completing a referral and communicating a treatment plan back to the primary care provider. One of our aims is to really provide predictability in cost and operation, and we found that these process measures really do allow us to understand how dependable the system of operation is to achieving oral health integration and coordination. And so all the clinics that participated collect data on a monthly basis. That data is used to inform the participating clinic teams, how the changes that they're making in their practice were really impacting the system. So this is just an example of some of the run charts that are shared monthly with the clinics that participate. So lessons learned. What did we learn from the experience that we've had over the past couple of years? The graphic that you're seeing here really combines the lessons learned while trying to create what we call an interprofessional oral health network within the various communities that we've worked in, and sort of tries to distill that down into the most important factors that seem to influence the success of interprofessional practice within a community. This is not to say that you have to have all 5 of these factors to be successful, but we found that these are the areas to focus on when working towards interprofessional oral health networks in the community. So there's 5 factors here that are identified. I'm going to highlight just a few of them. The dental referral networks, obviously having a strong dental care team, whether it's within your own system or in the community, that the primary care site can refer their patients to is really key in ensuring that the oral health needs are met. The medical teams really need to rely on the dental referral networks to provide treatment to patients who need the surgical interventions. Health information technology, that's a big one. Having HIT that's efficient and effective to communicate between the medical and dental teams is a huge factor. But also it's a great area of challenge because medical and dental HIT are so siloed at this point. Ultimately, how we provide care to our patients is transitioning from 2 siloed systems working independently to having 2 systems that work together and share oral health outcomes for their patients. A few other lessons that we learned along the way that are more at the clinic level, I would say, that are sort of central to the framework and how we work with medical practices that have participated. The first is the notion of one more thing, that oral health cannot just be one more thing that's added to an already packed visit for the primary care providers, but rather we've learned to really focus on the importance of looking at the risk assessment, oral health risk assessment as a tool to have a conversation with patients about their oral health. And that conversation can be sort of naturally woven into conversations that they're already having with discussing things like diet and nutrition. So to go along with that, we've also learned that the co-creation of oral health self-management goals with the patient is really a key factor in driving behavior change and knowing that the modification of their at-home care is a huge predictor of success. So we spend a good chunk of time working with the medical teams on applying motivational interviewing concepts to oral health. So we've had a few years to test and further develop the More Care model, and we're really excited to begin diving into opportunities to further improve and test the model. One of the key areas that we're looking at is the improvement of the HIT infrastructure that will allow for more coordinated oral health care. As I mentioned before, HIT has been consistently a challenge in all the states that we've worked in, and so we're working on finding solutions to better address those barriers through technology. Another opportunity that I'll note is thinking about business and care solutions for the next era of healthcare. We're really looking for a bottom-up approach to new reimbursement and payment methodologies. So I'm really grateful for the time to present our model, and I'm going to turn it over to Kimberly.
Great, thank you, Kelly. Let me just get my slides back up here. So my name is Kimberly Robbins, and I'm the clinic administrator for Child and Adolescent Clinic. We have a privately owned pediatric practice in Southwest Washington. We have 2 sites, one in Longview, Washington, and one in Vancouver. We have 12 pediatricians, 2 nurse practitioners, and our practice is 75% Medicaid. We started with oral health. Our first foray into that was in 2001 when we did a clinical trial of doing fluoride varnish application at well baby exams. And that project went really well. It was an interesting concept. It was the first I had heard of integrating oral health with primary care. And then in 2005, we took training from our Cora Health Foundation in fluoride varnish application and doing family oral health education and building in an oral assessment and referral process for dental home into primary care, and fully implemented that program over the next 4 years by 2009. As we said in the introduction, our practice is a really strong proponent of oral health and primary care because we've seen really positive outcomes for our families and for our practice. We've seen a vast improvement in carry rates at kindergarten entry in our community and a decrease in severe carry rates in early preschool age children. We found that the funding support between Medicaid and commercial carriers more than covers our overhead, so we're able to sustain our program for 10 years now. So some of our successes, we had 2 local pediatric dentists that did dental restorations under anesthesia, and since implementing our program, we care for 2/3 of the children in Cowlitz County. So when we do something, it hugely impacts the population, for the pediatric population for our area. So there was a pediatric dentist that is a pediatric dentist that does dental restorations under anesthesia when the child has such severe caries that it can't be, they need to anesthetize the child to fix it. And he used to do those 4 to 5 days a month, and is now down to doing them only 1 or 2 days a month because the rate of severe caries in our community has gone down so much since we started this program. So we know that it's really increased it's really had an impact on reducing caries for our community. We also know that the rate for the number of children entering kindergarten with dental caries has drastically dropped over the years that we've done this program. And I wasn't able to get the specific numbers before this presentation today, but we do know that they've gone way down. To look at the clinic flow for how our practice operates our oral health care program. When the patient comes into reception, they're given a handout that talks about, especially for the first the first evaluation, which is usually about 6 months, we introduce the program by giving them a handout at the front desk saying that why oral health is important, what we're going to be doing today as part of integrating oral health to our practice. And it talks about, on the opposite side of the form talks about aftercare for when we've applied the fluoride varnish. Then when the medical assistant rooms the patient, they use a flip book that provides the family oral health education component. And we got that flip book from our CORA, used to be Washington Dental Foundation. After we do the family oral health education, the medical assistant applies the fluoride varnish and asks the family if they have a dental home, if they're already connected with a dentist. Then when the physician comes in to do the well exam, he performs the oral evaluation just as part of the well child exam. So he's already looking at the child's mouth. He's already looking at dentition. So with the additional training that they have, they're able to make appropriate comment and referral if necessary. Then the medical assistant will have recorded whether the family has a dental home or not, and if they don't, the physician will talk with the family about the importance of connecting with dental care, and we'll put a referral in to our referral department, who then puts the family together with a dentist. So our referral process to the local dentist includes contacting the dentist, letting them know that the family needs an appointment. We give them all the family contact information, and the dentist then calls the family to schedule the appointment. And then we let the family know if they haven't heard from someone within a week or two to call us back, and then we follow that through to make sure that they get connected. The services for documentation of the family oral health education, the fluoride varnish, and the physician's oral evaluation are all auto-templated in our EMR, and so that documentation happens pretty smoothly for them. And then the services are auto-billed through to our billing department when the MA or the physician checks off that they've completed that task. Some of the early challenges we have, exactly what Kelly was pointing out, the receptionists see this as one more form they have to hand out and explain, and the medical assistants saw it as one more step in the patient preparation process. So I think we launched that a little too soon without getting their buy-in. So we assembled a team and got better input from them on process design, and implemented the solutions that they suggested, which made patient flow go better, increased our rates, got better buy-in from them, and had more consistency. We had held meetings within the different departments to share the data with them about the outcomes that we know we'll see for for increased fluoride application and the increased revenue that the program would bring in, and then would talk with each department about their role in achieving that. Getting their buy-in was huge in improving our rates. Another one of the challenges we had in the beginning was working on the timing of when to do the fluoride varnish application. Doing the family oral health education, when you do that, it didn't impact flow as much, but when to do the fluoride varnish was a bit of a problem. At first, we did it prior to the physician's exam, and then the physicians were saying, well, but now the baby's all upset because you've been messing with their mouth and, restraining their hands while you're applying the fluoride varnish for little babies. And so they didn't like that very much. So we started going to doing it after the physician exam. So the physician was done, the medical assistant would go in, do the family oral health education, do the fluoride varnish, and then the parent would leave after that. But we had very low rates then because the parents would forget about it and leave, and we didn't miss the opportunity to do the fluoride varnish. So we changed that back around to doing at the, as part of the patient prep, and that's where we settled. That has seemed to work much better. Another one of the challenges we had was that our satellite office didn't have had very low achievement rates. We think that was because their training was remote through Skype, and they just didn't physically buy in. We also didn't have a champion at the site. So we changed that to having a clinical manager visit every week and focus on the dental program, find out what was working, what wasn't working, and make the necessary tweaks for that site to make it work. We also started publishing reports of which physician had the most services provided to his patients, and then the medical assistants sort of saw that as a little competition. So then we would find if one medical assistant, for example, had better success at getting families to consent to having fluoride varnish, we'd find out, what are you saying and how are you saying it? Why is that working? And then we taught that to the other medical assistants at the various sites and would improve their rates too. Initially, when we started our program, we were only applying the program to our Medicaid population, and because at that point we only had assurance that those services would be covered, and we found that the medical assistants would get busy and they don't have time to assess, do I do this for this patient? Is this part of the well exam for this 4-year-old or not? Well, I have to check out what insurance they have, and they would get busy and just drop it. When we applied it universally, so that all families that we care for had dental services provided at every single well child exam, it was consistent across the practice, and that improved our achievement rates a lot. Billing challenges that we had when we started our program, the Affordable Care Act was not yet in place, so commercial carriers were all over the map on whether they covered fluoride varnish application or not, and at that point, very few of them covered family oral health education or the oral evaluation. After ACA, there was a lot more consistency in getting fluoride varnish paid, and it remains inconsistent for whether family oral health education and the oral evaluation are paid. Another conflict was that some of the commercial carriers require the use of D codes, of dental codes, and some use the American Medical Association's CPT codes. But there are different codes, D codes and CPT codes, that describe the same service. So it becomes a challenge when you're working with commercial carriers about what does that carrier want? Does that carrier want the D codes or the CPT codes? And what diagnosis code do they want with it? Do they want a dental diagnosis code or a well child diagnosis code? So it was a challenge for a while in playing with that for the commercial carriers to find out which combination got them to pay the claim. So a little bit of a Simon Says game that we played for a while. I would make a recommendation that you use your state-specific Medical Group Management Association listserv to get help on billing, because other people in your state will have figured out your state's commercial carriers' policies, and they can help you figure out how to get your claims paid. So for lessons learned, I guess I would say I recommend you get everybody's input from the start. We found that applying the program to every patient made it much easier to build smooth patient flow, and it improved our staff buy-in. Listen to your champions and your staff and adjust the flow that allows the program to work best in their individual environment. I know that I have a tendency to sit down, decide on a process, and say, great, this will work, guys, and then I take it down to them and they say, you didn't think of a whole lot of things. So by adjusting to their input, I know that they're a valuable staff. I know they're a great team, and when I listen to them, things work a lot better. And the other thing that we found was sharing statistics and sharing achievement rates among staff gave us a lot better buy-in. Our program is definitely financially supported. Having the program be universal is what led to our success, though. The Affordable Care Act helped with the reimbursement, at least for fluoride varnish, but since our practice is 74% Medicaid, the commercial revenue isn't a driver behind sustainability for us. So in 2010, the first year that we had the program fully implemented, our revenue was $12,000. In 2012, we turned up our focus a little bit more and turned up our focus more for staff, but the physicians were still required to individually order the services, or they weren't done. So we increased revenue to $16,000 that year. By 2014, when we had it universally applied, it was auto-ordered through our EMR, and the Affordable Care Act had been implemented. Our revenue went to $261,000. In 2017, we were at $281,000. In 2018, $283,000. So certainly the program financially supports itself. Remaining challenges that we have are that parents decline fluoride varnish out of fear. And I can't speak to the whole country, but I know Portland, Oregon, for example, has a ongoing and continuous debate about fluoridation, and that sparks because one of our satellite offices in Vancouver, Washington, right across from Portland, Oregon, we do have more families at that site decline fluoride varnish. And some of our commercial patients decline it because they're unsure if they're going to have coverage for it. Our practice is to universally apply our oral health program, and if insurance doesn't cover it, then we waive the fees. So it isn't an issue for families, but they still have that concern. These last couple slides just look at different resources for flip charts, for toothbrushes, things like that. Our program does provide the family with a toothbrush at the time we're doing the family oral health education at each well-child visit. So I just supply these last slides for that. So thank you for the time to present this to you, and I'll turn this back over to Ann.
Well, thanks so much, Kimberly, Kelly, and Aneta. That was just terrific. And we have sufficient time for questions, so I really appreciate your presentations. And we've got a lot of questions. There's now more than 325 of you on the line, so we can't possibly answer all of your questions, but we will do our best. Let me start with a question that came across the transom, and of course this is dependent on the state that you're in. I'm curious what practices do when there are few dentists in your state that take Medicaid and your patient population is on Medicaid.
So this is Kimberly. We are in our area in Southwest Washington. We are very fortunate to have partnered with pediatric dentists that take our Medicaid patients. So I do know that's a challenge, but we have found that by partnering with the dentists and having conversations with them, we've been able to open some access. And our clinic's policy, when we do referrals, when a family comes in and we're connecting a family with a dentist because they don't have a dentist yet, we do not refer our commercial families to dentists that don't also take Medicaid.
Well, that's certainly a strong signal then to primary care practices in your, dental practices in your area. Another question is and I'm sorry if people are hearing feedback, and I am, but I'm asking the speakers if they could all mute because I am hearing a little bit of feedback. That's better. Thank you so much. Wanted to ask the speakers to comment on any efforts they've seen to integrate not only oral health into primary care, but also behavioral health. And I'm thinking of one of the slides that Kelly advanced, which is, when you think about comprehensive care and you understand the interaction of behavioral health and physical health and oral health and physical health, we really want a delivery system that looks at the whole patient. So would anyone like to comment on any efforts they've seen to really look across both physical, dental, and behavioral?
This is Kelly. I'll just say that that is certainly, looking at the behavioral health is certainly something that we are interested in. I think to date, the programs that we've worked with have been focused solely on integration of oral health and primary care, but the behavioral health component is something that has come up many times and is something that's of interest to us to continue to explore and see how we might be able to integrate oral health as well.
Thanks. Anybody else want to take that question?
This is Kimberly. Go ahead.
I was just going to add that a little over a year ago, I believe, that I actually did a webinar, which was really more of a conversation with Dr. Renee Joskow at HRSA. We did it for a Bureau of Health Workforce webinar, and it was on that exact topic. And there was a lot of, collective brainstorming, both on our part and the part of the audience listening to the webinar, about all of the many ways that behavioral health can be integrated into oral health care. We know there's so much overlap and back and forth across the kinds of issues that come up, and the impact that behavioral health has on the ability of the patient to actually provide it, to perform activities of daily living, as well as oral health providers increasingly looking to behavioral health to help them figure out better ways to engage patients who may be reluctant or afraid to see a dentist. So again, I think we're just at the crux of beginning to see, now that behavioral health has been integrated, we're beginning to see more attention being paid to that issue. I think it's an important one.
Thanks a lot, Aneta. I thought I might have heard one of the other speakers who wanted to weigh in here.
Yeah, this is Kimberly. We have integrated behavioral health at our Longview practice and are very, very close to having it at our Vancouver office. So we worked with our accountable communities of health in Vancouver. We work with Southwest ACH, and developed a program to implement behavioral health there, and with Cascade Pacific Action Alliance in Longview for our integrated behavioral health here. So we're finding the pediatricians and working with the mental health professionals is been great. The families love it, and the families are engaging in care a lot sooner and a lot more fully since we're providing it in our offices here rather than having them go elsewhere. So we're still very new to it, but we can already see the impact on our families.
There you are embodying then that warm handoff, which people say really enhances the chances that the patient is going to get that additional service. Here's another question. One of the participants in the webinar wanted to understand about the integration between medications that are prescribed and how PCPs and dentists are sharing information, particularly as it relates to opiates and other pain medication that may be highly addictive, and we need to be careful about prescriptions. Wow, very quiet out there. I'm hearing crickets. Are we, Aneta, any efforts that you know about sharing information related to these prescriptions, or anybody else on the line?
Well, I think that I'm not aware of that information in terms of actual usage being shared. There is significant attention clearly to this issue. One of the biggest areas of concern has been the emergency rooms, where patients have come in with a toothache, ostensibly a toothache, and for years, for better or worse, were sent away with prescriptions for potentially an antibiotic for an oral infection as well as a painkiller, and often would fill the painkillers. So we know that this is an issue, and I think we're really, HRSA and others are really attempting to address it. In terms of sharing other issues related to pharmacological impacts on oral health, we know that many of the medications, particularly for older and chronically ill patients, end up creating xerostomia. So we have engaged pharmacists now and some of the pharmacy national organizations to really work with pharmacy with medicine to really be clear with the patient when they come in to pick up a prescription from a provider that there are potential side effects that they need to be aware of that may affect their oral health.
Great, thank you. This is a question about training, and I know, Kelly, you really talked about the training that was developed by the Society for Teachers of Family Medicine and how successful it's been, and the ways that it's enhanced primary care clinicians' competency in this area. The question was about how long this takes, and is that training sufficient to address all the kind of basic oral care needs that patients have, or do you find that additional training is needed?
So for the primary care providers that participated in More Care, we really, it was a combination of having the Smiles for Life modules, which provide an excellent overview, but then also having some in-state, in-office types of training where the providers are able to actually, try applying fluoride varnish, so things like that. So there's sort of both of a didactic and a clinical component to those. Those look different from state to state. In Colorado, there was the Cavity for Free at 3 program. In Pennsylvania, there is an AAP program that was provided to the primary care offices within their office. Those are usually fairly short, and then I think most would be able to be taken place over a lunch hour or just a few hours. And so those typically are sufficient to be able to get the process started. And then our collaborative effort would sort of continue to provide that feedback and any additional didactic needs that were found.
Terrific, thank you. Another question was trying to get a sense of, for a given primary care practice, and maybe you can reflect on how big your practice is, Kimberly, in terms of number of clinicians. How many dental providers do you need in a referral pool to make this work? I think people are just trying to understand how would you operationalize something like this?
We have 15,000 patients, and the number of dentists that we refer to, I'm just trying to list them off here real quick. And we are referring to 4 dentists. 4 practices, I'm sorry. One is a single practice. That one's an individual dentist. Let me just count this real quick. I think there are 9 dentists that we're referring to. But I have to say, other than Firstborns, most of the families that come to us are already, their first child created a dental home, and then the subsequent children are going to those practices.
Super. I think we have time for one last question. I'd like the experts on the phone to reflect on what are the payment barriers that get in the way of this kind of integration between primary care and oral health, and any ideas about innovative payment models that might address those barriers.
So I would say that, because dentistry is really built on sort of that surgical intervention model, it's really geared more towards high-risk patient encounters, which doesn't necessarily mesh well for striving for wellness and sort of limits change from a volume to value platform. So while the benefit design is really based on increasing chances of surgical intervention, I think interprofessional practice is really geared at reducing or getting rid of disease, but dental care teams are rarely paid for health and wellness prevention.
Thank you. And I really want to thank all of our presenters. Aneta, Kelly, and Kimberly, this was a fascinating webinar. I'm sorry we didn't get to all of your questions, but we do really appreciate everybody's participation, and we've held very strong on all that dialed in. Please take our quick survey that will get posted shortly, and also there'll be a survey in the follow-up email that you all receive. We will be putting this webinar and the recording on our website, so if you've got colleagues that weren't able to join today, you can send them that link. And thank you again for a really wonderful and very informative webinar. Have a great afternoon.